All right. So the clock just struck 1 at CWIS time, which is Mountain Standard Time. So why don't we go ahead and get started with our chest wall injury case series review. Before we get started, just a couple of rules of engagement. First, we really encourage questions. So please feel free to submit questions into the chat feature on Zoom. Or if the spirit moves you at the end of each talk, feel free to unmute yourself and ask, although we encourage the chat feature first and foremost. For the people that are participating in the call and not presenting, please make sure you're on mute. You'll know you're on mute because the microphone on your screen should be red. Just a quick review on the format. Each of the presentations will be about 5 to 7 minutes long, and then we'll have about 5 to 7 minutes for each question or for each presentation at the end. Quick note, we record now all of the case presentations, so feel free to review the prior case series at the link on the screen, and that's also where you can register for the next month's case series. So with that, I will stop sharing, and I'm going to pass it over to Dr. Richard Miskimmings, who's a trauma and acute care surgeon at at University of New Mexico, where he's also the medical director of the Emergency General Surgery Services, and has a strong track record of unique cases that he presents here at CWIS. So I'm really looking forward to this. So with that, I'll hand it over to you, Richard.
There we go. So thank you. Oh crap. Let me fix my screen share now. Fix it. Is it still on presentation mode?
Yeah, it looks good.
Oh, well, now I screwed it up. Let me try this one more time, even though I practiced beforehand. Okay, there we go. So thanks. This is an interesting case that we had recently that was a sternal reconstruction after a fairly extensive resection. And so this was a 34-year-old man that he was assaulted with some object, is a bat or a pipe or something along those lines. And he ended up with multiple rib fractures. He left against medical advice at one point in time, and then also represented and developed a infection of his sternal hematoma with the resultant osteo of his sternoclavicular joint and his destruction of his sternum. He had PTSD. He was a smoker. Other than that, he didn't use any prescription medications. His thoracic injuries consisted, he had a series of bicortical rib fractures on the right of 5 through 8, and then on the left, and then unicortical on the right, 4 through 8. And then he had this displaced sternal fracture that was, it was pretty impressively displaced in multiple locations. And this was primarily, I thought, being stomped on a few times, according to him. And so he left against medical advice after 1 day, 2 days. Then he came back a week later with significant pain. And then also he developed a pretty impressive infection of his sternum, and then also of his, he developed an empyema of his left chest. And so he was taken on day 1, which is 9 days after his injury, for an incision and drainage of his sternal abscess, which we then took him back the next day and required a fairly extensive resection. This is his head and neck up here. We resected the majority of his sternum. It just kind of came out mostly. There a little bit required some more aggressive treatment. Then we resected the third of his clavicle and the sternoclavicular joint to get rid of the infection that was there. And then we placed a irrigating wound vac on there. mostly because we had it available to us that day. So then he went to the OR a few more times. We took him back and then debrided him. And one of the key kind of points that we used on this was we debrided him back to healthy sternum, and we sent it to pathology to assess for osteo of those bones, so that when we knew we had a clean or a mostly clean resection margin. So after that, he had a fairly large defect of his chest, and he didn't have great function of his right upper extremity as well. And so we took him on day 13 post injury to fill this dead space. And these kind of sternal reconstruction is something we've been working on with some of our CABG patients that have had bad experiences throughout the state. And one of the things we've learned is that some of the dead space issues that we had. So this is day 13 after his injury, and you can see that we have a pretty good, clean, healthy wound bed. And so we brought up a laparoscopic pedicle-omental flap based off the right gastroepiploic, and then we tunneled it through the same plane for pericardial window. And he had about an inch, 2 centimeters of sternum left at the bottom that we tunneled it under, and brought this up. And then due to paranoia more than anything, I let the omentum sit for a couple days to make sure it stayed alive on his chest. And so we just put a wound bag back on the omentum and let him continue to heal from that. So the final stage of our reconstruction, or day 5, was 20 days post injury. And we used the sternal midline compression system and Talon to fixate to the ribs, and then to span the defect where the omentum is under, and then to fixate to the ribs the other side to add for a stability of the chest and the chest wall. And this is kind of that area is the system itself ratchets into place. And so you can get a good approximation and then do some closure. However, if there's not enough tissue behind there, then you end up with a space for lots of things to happen. And since this was a infected field at one point in time, and probably to an extent still at this time, we went ahead and placed the stimulant absorbable, the calcium carbonate absorbable antibiotic beads with Vancomycin, myosin in there and then did bilateral pec major advancement flaps and closed it. I don't routinely get CTs post-operatively, but 2 weeks later, he fell at a bus station and came back in as a trauma patient. So we happened to have a CT after that showed that he had really pretty good approximation of everything, that he, the defect was close. He had chest wall stability. There wasn't any infectious process that was there. And he actually discharged from this one to rehab, where he did really well, and hasn't had to have sternal precautions or anything. And so I think the learning points for me in this case and in all these is with the infection is that aggressive debridements, we made sure before we put the plates on it that our path report came back that they didn't have osteo on them, not just from feeling the osteo, but from that, and then obliteration of that space when the sternum, when we use this compression system and bring it together, there's a dead space that we just can't seem to get rid of, and the omentum is what we have elected to use to obliterate that dead space, and it works really well. And then, as with all trauma operation, I think staging it in the appropriate manner can be beneficial in order to allow for talking to people, and then also allow to make sure that when you're doing something new that it's going to work and that you don't have to do it all at once. So, so it's an interesting case. We learned a lot. We're starting to do a lot more of these kind of sternal reconstructions with focus on function as opposed to just tissue coverage. That's
Awesome. Thank you, Richard. I think now everyone on the call is going to send all of their sternal non-unions your way. So be careful what you wish for. There's a couple of questions coming in through the chat. First from, looks like Dr. White, how did you manage your empyema that you had at the same time?
So we did a left thoracotomy and we did a decortication and cleaned it out aggressively at that time, and we kind of waited for that to resolve as well. And we treated, it was an early empyema, as opposed, since he represented pretty quick, I think we would have been a lot slower to have done it, I guess, if it was truly like, the 6-week empyema that's everything socked in, but we were able to get everything cleared out. So.
Okay. Thanks. And then it looks like Dr. White is also asking us to give us an update when he comes back at a year, hopefully not as a trauma patient again, but based on his history, who knows?
He probably will. We'll probably have regular updates from his trauma activities. So.
Quick question for your for the sternal system that you used. Are those bicortical screws or are those unicortical screws that are just long? And if so, how did you decide the depth?
So they are unicortical screws, and I just measured the ribs themselves for them. The system is, again, a locking plate, unicortical, and so it comes with the caliper to measure it. And we also, I didn't mention, we put some bone matrix behind there too. I don't know why, but the orthodox told me to. So,
Richard, I hate to dominate the chat here, but this is just fascinating. And thanks again for bringing us a wickedly creative presentation. What that piece of hardware looks impressively complex from a bacteriologic standpoint to me. It looks like lots of hiding places for bacteria. Are you concerned that is not going to be, you're not going to be able to sterilize that buccal system with all those different holes and corners and crevices?
Yes, to an extent. That's one of the reasons that I like to use the Omentum for this. And I essentially bring up posterior and then over the top also. We've had a lot of really good success with the Stimulin beads in just incredibly infected fields, sterilizing the field using them. And we're in the process, one of our plastic surgeons here used to do a lot of kind of work with it for chronic osteo and flap coverage. And we're in the process of writing up some of our experience with it right now, but we have found them to be, and I reposition after, you take a good picture, and I take my beads and I put them on the buckle and I move them around into the little spots over there too, so that the distribution of that antibiotic is on those. I don't know if that works per se, but we've, like I said, we've had some pretty impressive hardware, even hardware salvages with our orthopedic colleagues using those and some irrigation. So if it pusses out, I promise you that I will confess to the group that it happened.
One other question from Chris, and I think you alluded to this a little bit with the bone matrix that you suggested that you were putting in, but what do you think the metal fatigue is going to be like for that long spanning bar?
I'm not 100% sure, to be honest. In this one, we're hopeful that with putting in the bone matrix that it fills in over time, and we'll follow him with that. It's a fairly robust system. And I look with this guy that he's one of the larger spans that we've done. Most of the time when we bring these together, we have a little bit of sternum left, and we're only spanning maybe a half a centimeter to centimeter gap with that. So I don't have a good answer on that yet.
Awesome. Well, thanks again, Richard. Great case, and I'm sure this will generate discussion and maybe future cases down the road.
Thank you so much. Appreciate it.
With that, I'd like to hand it over to Mark Crisco, who's a surgical critical care fellow at the University of Utah, who's going to be presenting next and introduce our other speaker. So Mark, take it away.
Yeah, Sarah Ann already made fun of me for having one of my residents present the case for me, like I was trying to bail out on it. I'm not trying to bail out on it, Sarah Ann. Ryan Robbins, Dr. Ryan Robbins is an amazing chief surgical resident in the University of Utah. And she did this case with me. And so I twisted her arm first to join CWIS. So she's one of our newest members to join CWIS. She joined a couple days ago. So welcome. And I can see you in the chat, Sarah Ann. Jeez, rough crowd. So yeah, she did this case with me. I'll have her introduce the case. It's nothing like the last case, not exciting. The reason I'm presenting is I kind of want some opinions on my outcomes that we've had with the case. So Dr. Robbins, take it away.
Thank you. Yeah, so we will be presenting a traumatic lung herniation through the costochondral junction. So this is a 55-year-old male who was a blunt polytrauma 1 activation from Montana. It was a highway speed MVC rollover understrained with ejection. He had multiple injuries, including some significant thoracic injuries, a right first through third rib costochondral junction fracture with a lung herniation, and some additional right and left rib fractures, as you can see, along with pneumothoraces, some facial fractures, and some orthopedic injuries as well. The patient had a simple displaced right first through third anterior rib fracture at the costochondral junction with lung herniation. That's the top image that you can see. He also had some simple undisplaced bilateral 5th rib fractures and a simple undisplaced left first and lateral 8th rib fractures. These were associated with that lung herniation, pulmonary contusions, lacerations, and some pneumomediastinum as well. The patient was taken to the ICU after stabilization in the trauma bay and had a preoperative bronch and EGD to rule out any aerodigestive injuries prior to proceeding with the OR the same day. He was placed in a supine position, and we made a transverse incision over the second rib space. This allowed for us to do an open lung reduction. We did attempt as best we could a primary intercostal tissue repair of that space, but his tissue was pretty macerated and it was difficult to get a really good closure. And then we proceeded with fixation of the second and third costochondral junctions using unicortical 16-hole plates across the sternum and ended up replacing his chest tube intraoperatively as well. Post-operatively, the patient had some repair of his ortho injuries. He also had a scalp hematoma that needed to have management by plastics. And unfortunately, on hospital day 3, he had a repeat CT scan due to concerns for PE, was diagnosed with a PE and started on systemic anticoagulation. As you can see, the top image is a very small residual herniation of the lung as read by radiology. That was at the level of the first rib fracture, which was not repaired intraoperatively. And then the second and third images going down are of the second and third rib repairs. Ultimately, the patient did fine. He was extubated, transferred out, had repair of his facial fractures, and then was discharged to a skilled nursing facility. Unfortunately, we haven't had any follow-up with him in our system. And so some of the discussion points that we wanted to talk about is, from a review of the very sparse case or literature, there are some case theories that say maybe there's a role for non-operative management of these lung herniation patients. I don't think that it might apply to this patient, but there is some evidence for non-operative management, especially in pediatric cases. I know we wanted to talk about whether or not fixation of the first rib would have been warranted, and what to do about this small residual lung herniation, if that's going to become a problem or not.
Yeah, thank you so much, Dr. Robbins, for introducing the case. The reason I brought it to the review is I really had questions. You know, I've done my own review of literature here, and this was my first case as alone as an attending or fellow doing a costochondral junction repair. I had done some before, but I didn't attack the first rib space. And the rationale being, well, at first I thought it would just reduce, indirectly reduce when I attacked the second and third rib space. And it kind of did, but you can see on that day 3 scan that there was a little bit, I mean, it's small, you can see it there. And I don't know if that's consequential or not. I don't know if anyone's had a case like this or if they would have repaired the first rib in that scenario. I opened the floor for that reason. If anyone has any comments.
Awesome. Thank you, Mark and Ryan, for interesting presentation. It looks like Dr. White is not impressed with the CT and doesn't think that the residual hernia is real. And I'd probably second that. I don't think that that's probably going to be consequential in the long run for the patient, particularly when you look at the rest of the burden of injury they experience. So one person, go ahead.
Yeah, I mean, and I mean, I haven't had this case before. I've never re-CT these people before. So I didn't think it was going to be consequential, but I don't know if anyone's had a nightmare story of them recurring at that first rib.
We'll see if anyone puts anything into the chat. I guess one question I had is, it sounds like you're able to get this patient to the operating room pretty quickly, and it looks like they had fairly bad lung contusion as well. But do you think you kind of got them taken care of in kind of like the honeymoon period before their pulmonary contusion started blossoming? Like, do you think you would have hurt yourself if you delayed any longer? Just interested to hear your thoughts on that.
Yeah, I think because of his postoperative course, I definitely hit him in the right time. You know, I got him straight upstairs. I did a bronch and an EGD that was negative, and then an hour later, I brought him to the OR. In the next 2 days, his contusions blossomed. And that, he was tachycardic, increasing vent requirements. So I did hit it in the right spot because that's what prompted that PE protocol CT too, because he was just worsening, mostly because of his contusions, but also because he had a PE. So I did luck out in that respect. Yeah.
I'm going to grab the microphone again. I know you guys get tired of hearing me talk, but I'm going to make the challenge that I've never seen a lung hernia through a intercostal space that is of normal dimension. So I think I don't think you were remiss in not putting mesh on your intercostal repair. I just don't think lung can herniate between 2 ribs that are normally spaced. And every lung hernia I've ever seen involves ribs that are diastatic or separated from each other significantly. So I think what you did here was the right operation, and I'd love to hear anybody else's thoughts about preventing lung hernia or treating lung hernia.
Dr. White, you kind of briefly mentioned it, but we were trying to put crap tissue back next to in the intercostal space. That's interestingly not where the lung had herniated through. It literally herniated through the costochondral junction fractures, not the intercostal spaces. But that tissue that we put back together was terrible. And it sounds like you wouldn't have put a mesh there, but I was wondering if anyone else would have.
So we have about, I think, 4 or 5 of these in the last year that have just been complete disruptions of the costochondral junction. The lungs herniated out, and on all the CT scans, there's always, this probably speaks more to my operative skills, there's always some small segment of lung or something that's popping up in a spot, and I don't think there's any real consequence to it because it scars in that spot, and it's never big enough to do anything. But I think that what you did was exactly the right thing in the right place. And going after that first, I just think that most of the time you cause more harm digging everything out than you would get for fixing that tiny little thing that came out. So I don't routinely put mesh in any of those cases. So
awesome. Well, thanks for the feedback. Thank you very much.
And as Ryan put in the chat, it looks like it's an opportunity to do a small case series. And I could definitely see how the CWIS membership could get together and identify small lung hernias and see what sort of meaningful issues long-term they have. So thanks, Ryan, for that. All right. With that, let's hand it over to our last presenter, Colby Elder. Colby's a fourth-year general surgery resident at UPMC Pinnacle in Harrisburg, Pennsylvania, who's currently applying for a fellowship in CT surgery. So with that, Colby, why don't we have you share the screen and you can take it from there.
All right. And it looks like I got taken off of the manager position here. Sarah, can you reauthorize me to share my screen?
Let's see. Sarah, are you on? If not, I think I can give it to all participants and then you can start sharing, Colby.
All right.
All right, let's see if that works. Are you able to share now?
You guys able to see that?
We are.
Great. Yeah. All right. Thanks for having me. Get started here. So this is a case of a 68-year-old male who presented to our hospital with right flank pain, shortness of breath, and persistent cough for over a month. He was seen in the ED last November after having an acute, pretty violent coughing episode and had some acute right chest pain after that. He was seen in the ED, and you can see his chest x-ray taken at that time on the right, and it was unremarkable, so they sent him home with presumed costochondritis. He was also seen at outside hospitals maybe more than one time, and is entering with steroids and pain meds for his cough and respiratory symptoms. This had worsened, and he eventually returned back to our hospital about a month later. He has a history of asthma, although suspect he might have had some underlying COPD. Instead, he has obstructive sleep apnea, 30-pack year smoking, and you can see his BMI is 39, which made his exam a little more difficult. And his meds are listed below as well. So when he came back, they ended up getting a CT scan for his persistent symptoms, and I'm going to play it here. There was no rib fractures that were seen on the imaging, but there was a widening of the right eighth intercostal space containing a mass that extended through the lateral diaphragm, and it comes down, you could really see it extends along the entire length from posterior to anterior, extending out. And the radiologist had some concern that this might have been a liposarcoma, but they couldn't really evaluate the full extent of it. And so we ended up getting an abdominal CT scan afterwards. You can see the mass really extending out there. You can see some bowel gas actually going in there too, in hindsight. And the the 9th and 10th ribs, they come down. You can see the rib, the costochondral junction right there, and then they kind of splay out and end. But you can see it's a little bit better in the coronal view of the abdominal CT scan coming through. But and the radiologist didn't see it, but looking at this in hindsight, we could identify that there was some simple displaced fractures of the 9th and the 10th right costal cartilage without any contact. You kind of see the turns into cartilage here, and then which goes a little more anteriorly, you can see it abruptly stop. Also see that colon going through there, as well as some vascular pedicle. So we admitted him for workup of this, although on this view we could appreciate it more likely to be a diaphragmatic and chest wall hernia. But we underwent right thoracentesis because he had a pleural effusion. We definitely want to make sure we ruled out any kind of malignancy before pursuing treatment for him. Thoracentesis was transudative and negative cytology. We ended up getting an IR biopsy of this, which showed a fat necrosis with an area of fibrosis. So he was scheduled as an outpatient to come back in for elective repair, actually. So during the initial case, during induction, he went to AFib RVR with pretty significant hypotension. The case was aborted. And getting cardiology on board, medically optimized him, and he went back a few days later at the end of the week. So how we approach this is we, double lumen, single lung ventilation, place central line, and epidural. We did a left lateral decubitus, bed flex the hip, did a flex bronchoscopy to confirm tube positioning afterwards. We started by making an incision over the lateral chest wall, kind of over the palpable hernia sac. It was fairly difficult. He had a lot of upper, trunk obesity. We went down, but before incising into the sac, we decided to, make sure that we weren't incising into any adhesion. So we placed a 5mm trocar in the upper chest, just anterior to the latissimus. And you can see here in the right upper image, we saw some omentum that was non-strangulated, not really concerning for any type of neoplastic process. See coming out of the diaphragm. And the inferior image, we're looking more posterior, you can see the lungs uninvolved and pretty clean contents there. So we decided to cut down over the hernia sac. We encountered the omentum in the colon. This is reduced back into the abdomen. We could see a peeling off of the diaphragm. And if you see at the image, this is what we suspected. I don't know if anybody's seen this before, but you see a kind of scar line going in kind of towards the inferior portion of the diaphragm, just lateral to the diaphragmatic defect there. And we felt like this was the attachment of the diaphragm, and below that scarring was really just lateral wall getting pulled up. This was about 2 months after the initial injury, so had time to probably stabilize but we measured the rib space to be about 9 centimeters. The diaphragmatic defect was approximately 9 by 6 centimeters as well. You can see the liver there kind of poking out through that image. We ended up deciding to do tioethibond with pledgets to close the diaphragmatic defect first. Do this using about 10 erupted sutures, and then use some oethibond through the chest wall, kind of superiorly. We did this going through here, diaphragm, and back up to try to isolate this repair from the in the abdomen entrance from the pleural cavity, so it doesn't interfere with the lung. Kind of separate those two cavities from each other. After we did this, we then decided in trying to create a tension-free repair. And after some discussion, we decided to use some, unicortical rib plates on the upper and the lower rib, so rib 8 and 9. And we approximated these using K-wires. I used 4 K-wires, and you can see here at the middle image, they're crimped down, and we have that really approximated well. After this was felt to be secure, we then tied down our sutures of the pledgets as well as the ones going through the upper rib space to help isolate, to pull up the diaphragm to isolate the cavity. After we felt pretty confident with this, we then put the thoracoscope back in, and we're pretty happy with that repair. We then placed a 28 French angled chest tube. After that, post-operatively, not too significant. You can see his PACU upright chest X right here with the plates, and you can't really see the chest tube, but it's in pretty good position. Post-op day 1, that evening, he had pretty significant vomiting, and he got a flat plate which showed really distended stomach. The overnight resident tried to place the NG tube, but was unsuccessful, and he ended up having it resolved after we stopped the epidural. You can see here in this next image, we just shows a good image of our plates and our repair there. Post-op day 2, pulled out the epidural because we weren't going to use it, and his pain was actually well controlled without it. Placed the chest tube with water seal. He actually converted to normal sinus rhythm throughout his course. Started PMI run, which he was discharged on. Post-op day 3, chest tube removed, and he was discharged the following day. We've seen in the office 2 weeks afterwards, and actually felt much better. And that really severe heartburn and nausea that he had even pre-op was also resolved, surprisingly, after this case as well. This is his chest X-ray, his 2-week follow-up. And then just as a learning point, we really wanted to evaluate this with the VATS beforehand, just to make sure that we weren't going to be incising into anything that we just happened to miss as a neoplastic process, and make sure it was free from any adhesions. Also, we want to try to get a tension-free repair. We decided to use plates and K-wires. We felt this would be a really sturdy an option, and we chose that. There was the cartilage that we could even palpate intraoperatively as well, but we decided not to try and approximate that to the other cartilage because we felt like this repair on its own was sufficient enough. There was some previous literature that I found, not an abundance of literature on the transdiaphragmatic intercostal hernia, but this one was just a review of the literature, and it did find that 2 of the cases occurred after violent coughing episodes. One was just completely repaired primarily, and one actually used mesh to close the diaphragm, and the ribs were closed primarily. There was another one that was a little more robust that had 38 cases, and 19 of them had diaphragm rupture alone, and the other half had involved the causal margin and a chest wall herniation. Now that one really tried to make a classification out of it, and they of course, all based off the costal margin rupture. And I'm just going to focus on ours, which is the top one, traumatic, diaphragmatic, and intercostal hernia. And for this one in particular, and they had different types of repairs that they classically did for all of these, but for this one in particular, what they did is a 5-layer double mesh repair. And I'm interested to see if anyone else has used this as well. But what they first do is they mobilize the origins of the serratus and external oblique. They'd use 2 layers of polypropylene mesh, one externally and one internally, after really creating a nice surface area. They'd sutured with tooth plugets, one on the outside, one inside, and used a Prolene suture for that. And they went 2 rib spaces above and 2 below. They also used some suture to approximate the space ribs as well. And the diaphragm was closed primarily using a 2-layer repair in their cases. Here's just an image of what it looks like after completion. So definitely, I think this one works pretty well at preventing, I guess, any recurrence adjacent to the initial hernia, but I feel like our repair probably is just as good of a job, if not better, of at least preventing the initial hernia space from recurring. And I'll see what you guys' thoughts were.
Awesome. Thanks, Colby. It was a great case, and it was actually remarkably well timed because we had a case presented at last month's case review series. A patient with a not exact but similar problem, where that Edwards quilt was utilized. I guess one question for you, kind of in your long-term management of this patient, what's your strategy for how long you're going to follow them down the road? Is this something you follow people out for a month and then say good luck, or try and follow them out for a year? What's your thought and plan?
Yeah, my attending was supposed to be here to help me out on this, but he got caught up in the clinic, unfortunately. But I'm not sure exactly how long they're going to follow him up for, but I feel like probably for a little bit more extended time period, just to make sure there's no issues with this, because it's really the guy's pretty obese and he has this chronic cough, and so there's going to be a lot of stress on the repair. So I'm sure we're going to be watching it pretty closely for a little more, at least a little bit longer.
And then while we wait for some other questions to come into the chat, do you have any concern about the K-wires bridging the rib gap, that over time you may run into breakdown issues with those K-wires as they're bent?
You mean into the ribs that they're wrapped around?
Mm-hmm.
Yeah. I don't think there was any concerns, brought up amongst both attendings that were in this case.
All right. Looks like Chris has a question or a comment. So yeah, Chris, go for it.
Yeah. Hi there. Great presentation. Thank you very much. The case you present, I think, is typical of the presentation that these people present. I've got about a series of 6 or 7 of them, currently 2 on my waiting list to be treated. And they are the obese and the ones who have a cough and suddenly they split it apart, the costal margin. And I think a lot of the case focuses on the costal margin and making that costal margin robust again. One of the things I've used is a longitudinal plate over the cartilage to stabilize that and then bring the ribs together. The fracture, I've got one case where the 7th, 8th and 9th ribs are fractured as a result of this, but they usually have this massive hernia. They present suddenly and they have the great herniation and they really are breathless, these people. So bringing all of that together, I think in essence is to see whether we can get them losing weight afterwards. As I say, I've got a series of about 6 or 7 of these patients, and they all follow the same course: cough, overweight, cough, a lot of pain, and then they become increasingly breathless until it's sorted out. So thank you for sharing how you've done that. I've had one case at Christmas which we dealt with. Unfortunately, he was an ITU a long time before I got to see him. And he was a liver failure patient with gross ascites, and he presented with pleural effusion and a diaphragmatic hernia. And I always considered that this was the defect in the diaphragm was like a right-sided Boktelek type defect, because it was as smooth wall as what you were showing here. and that he needed repairing of the costal margin and the diaphragm to deal with that. But his was due to liver failure and ascites, because he coughed that up and it went from there. But it wasn't recognized, and that's the problem, is you've recognized this. Quite often people are not recognizing this injury. They'll see the rib fractures, but they won't see the costal dehiscence, and that's the essence to it, is seeing the costal dehiscence and bringing all of that together. Thank you.
So, yeah, we did discuss about possibly placing some plates, like you said, across the cartilage. We felt like that would just be further dissection, and we were hoping that our repair would be good enough. But yeah, we'll see how his course plays out. And there was, and actually that second literature that I did present, that did say they routinely did plating over the costal cartilage to bridge that fracture in all those cases when it was just that alone.
I think this injury is a lot more common than recognized, and I think half the time is it's going unrecognized, and so it's great to see it and highlight it. Thank you.
I'm going to take an opportunity here to plug the CWIS Summit, which is coming up in a month, and I'm sure most of you know. You're either registered to be there in person in Denver or virtually, but we're having a panel session hosted by Dr. John Edwards, who's the author of that paper and that the series that you showed there, and we're going to address this this topic in a panel format. And we're also going to be shooting a series of videos called the Advanced Video Series, and we're going to demonstrate the exposure of this injury or this anatomy on a cadaver and recreate this costal margin disruption and the splaying of ribs, and then how to expose and how to fashion a repair. But I just want to make one comment about the chronicity of this injury. If someone coughs and breaks their costal margin and you happen to be, or they're fortunate enough to meet you within a few days or a few weeks, I think the repair is different than if someone's had this malady for years or months and years, because there's an extensive amount of foreshortening and remodeling of the intercostal spaces, and that spreading between the ribs becomes nearly fixed, and it's really a challenge to bring these defects closed without, you mentioned a tension-free repair, and that's, I guess what I'm leading up to is a question for you. Was it truly tension-free, or did you have to pull those ribs together quite vigorously with the wire? So there was a question interlaced in that comment, if you would, Colby.
Yeah, it was, I wouldn't say it was too much vigorous pulling on them to get them together, but there was some resistance. So there might have been, a little bit of tension on the rest of the chest wall to accommodate for this reapproximation. But it wasn't, I wouldn't say, too vigorous to really bring them back together.
I don't think in the chronic setting, and maybe not even in the acute setting, the costal margin repair alone is enough. It's cartilage. It's not terribly strong. Our plating systems are not ideal for cartilage, and I think it's probably not enough surgery just to bring the cartilage together and expect that to be your only means of repair. I don't think that's what Dr. Satur was saying, but relying on just bringing the cartilage together and closing that margin defect is not going to be enough surgery. Those patients are going to recur at a high rate for the reasons that we just talked about. You have to add something else, like you did.
Yeah, thank you.
I fully agree. You've got to add, I think you've done the right thing, which is reinforcing those ribs and holding them together. And then the costal margin repair itself is not enough, I don't think. And it's interesting seeing what you've done. You've used the plates and then you've used sternal wires around that to hold that together. So that's really, really sound.
Awesome. Well, not seeing any more additional questions in the chat. I wanted to thank you again, Colby. And I want to thank the rest of our presenters, Mark and Ryan and Richard, for putting the slides together and sharing with us their cases today. It was another great series. Again, just a reminder that all of these are available on the CWIS website, so you can review at your leisure any of the case series of months past. And finally, would end with again a plug for CWIS 2021. Hopefully we'll be able to see everyone in person at the summit who can attend. And if you can't, we'll miss you, but look forward to touching base with you virtually. So with that, we'll end the CWIS case series for March 2021. Thanks, everyone.